First class, second reader, we a long time to do it. But everybody's different. I had some friends that were like on it, and then it was me where I was not. But it eventually came around. It takes a little bit to pop in there. All right. So I think we left off yesterday with Wasa, right? Yes?
Yes.
Okay. So we're going to talk about Wasa. This usually happens in West Africa, most common, right? So those are things we want to remember. Most common happens in West Africa. CDC says that about 80% of these infections, people have mild disease, which is great, right? Because then we don't really have to do much. About 20% of them end up going to severe and multi-organ problems. Okay? How do you get this stuff? Usually from contaminated food with rodent urine, saliva, or feces. Rodent urine, saliva, or feces. Can we spread it human to human? Yes, we can. If we get infected, same deal. Urine, saliva, or feces. We can spread it to ourselves the same way. Okay. There tells you it's endemic in West Africa. The species is usually the multi-mammate rat. That's a whole bunch of different rats. So there's not serious specific ones. We've seen nosocomial outbreaks, not here in the state, but remember this is endemic over there. Over there, they don't have the appropriate things that they necessarily need to take care of themselves. PPE being one of them, right? So remember, urine, feces, saliva, usually in humans when we pass it, it includes vomit, okay, and or blood. So if I'm taking care of you in a hospital over there, I may not have appropriate PPE, so I may be touching some of that bodily fluid from an infected person, which means I may be able to get it, right? Which is why they have some nosocomial outbreaks over there, not necessarily here. Okay. Highlight pregnancy, specifically third trimester. Okay. We've highlighted pregnancy in, I think, 2 other ones thus far. This one is probably the worst because this one will cause maternal death as well. The other ones we really talked about, the neonatal, the infant, dying, still for abortions. Same deal here, but in this case, the mom could die too. All right? So I would say out of the 3 I think that we talked about thus far, this is probably the worst for pregnancy. And you're going to have, it says bleeding manifestations rare, not necessarily the case. If you go to severe, you may have internal bleeding that is not rare. All right? And there it says most infections are mild or clinical. That's 80% of them, which means you may not have to do anything. The body will recover. You should be good to go. Okay? So remember, the reservoir for this thing is that mastic rodent. So in your scenario, you'll be somewhere in West Africa. This one has real specific states in it, so I may use one of those for this. Just keep that in mind. So here's the distribution, right, of that little mammate species. It's basically all over from the top third of Africa down. But most of those occur in Nigeria, Sierra Leone, Guinea, and Liberia. Right? So there's 4 that are very specific. All right. This slide really tells you that there's been outbreaks over there. All right. As the populace continues to push out, they start burning bushes, they start knocking down trees and continue to push out. Where do you think those little rodents go? These little rodents are extremely adaptive. They like to hang out with us. So they're going to move into your house just like you move into your house. So they're going to spread that stuff all over the place. If you come in contact with any of that stuff, that's how they spread it. It's been such a big problem that they've created a response committee there. And usually what they do is they'll go out and they'll try to make sure that these things don't go into houses and people stop burning bushes and trees so that they stop going to people's homes. So here are some signs and symptoms. Incubation period usually 5 to 16 days, kind of long. The bleeding that occurs is usually from any mucosal area. All right? Any mucosal area. And you'll have fever, weakness, joint and lumbar pain. Prostration is one of those big ones, right? With the extreme weakness, fatigue, and exhaustion. All right? There's nothing huge there, but if you look at the bottom there, particularly severe for pregnant women and their offspring. Right? So this is one of those really bad ones for pregnancy. The other thing that this thing does like to attack is the inner ear. So your cochlea may be destroyed, in which case you may end up with sensorineural hearing loss that may or may come back depending upon how much it gets affected. But each one of these things likes to affect certain things. In this case, one of them is the inner ear. Again, it says about a third of the cases. Here is some conjunctival hemorrhage in the eye. Here's another subconjunctival injection. Okay. So, children hospitalization in West Africa, a lot of it is Utah-Lassa for kids. Okay. Swollen baby is one of those things that occurs with these little kids. All right. With their children, they may end up this way, but usually a lot of the neonates end up with what we call swollen baby syndrome, and that'll be showing up really enlarged, swollen, and really floppy. Okay. The cavity inside their bellies are usually swollen. That'll be part of that ansarca. They'll have general body edema. The prognosis for these little babies, very, very, very high mortality rate for these little babies. So prevention is key with this. All right. Because this is a viral hemorrhage issue, this is no different than any of the other viral hemorrhage stuff that we talked about yesterday. Right? The CDC is going to be off. Right? This thing attacks your liver is the other one that it really likes to target. So your AST will be higher than your ALT. These things are usually 10 times the standard normal range. You'll have the lymphedema, you'll have thrombocytopenia. You're going to do the serum, right? The ELISA stuff. For most of these cases, right? And I mentioned, hey, there's a small window there, right? Usually 5 days or so before the stuff pops up. But remember, most of these guys show up in your office with symptoms already. So the likelihood when you do their labs, it may already be positive. Because they don't usually show up to your office without symptoms. So at that point, usually they're already positive. Okay, they're beyond that 5-day window for your IgG or your IgM to develop. Remember, we don't do cultures on any of these things. These are really bad. Okay. If we do cultures, we've got to let the labs know. They'll tell us whether or not they can or can't, because most of these can be spread, and usually they'll put those in bio level 4. All these viral hemorrhages usually go to bio level 4, and most places just don't have bio level 4 capability or capacity. If you do have PCR, by all means, RT-PCR. All these viral hemorrhages are all RNA, so RT-PCR this stuff. Okay. That's quick. If they have it, and it's available. All right. This one actually has ribavirin as effective. Key point, if it's given usually less than 6 days, right, from the start of the illness, is what the studies say. Beyond those 6 days, it's questionable how much it helps. This is not a definitive treatment. This has just shown that it helps. Okay? We do not have any antivirals or specific medicines or specific vaccines to take care of us. All right? So Remember, if we can get ribavirin on board within the first 6 days, you'll have a better outcome for your patient. Beyond 6 days, it's kind of questionable. All right. Just for the same for all of them, supportive therapy is key. Supportive therapy is key. Okay? You got to look at the fluid. You got to look at the electrolytes. All right? Any of those imbalances, we're going to try to fix as part of the supportive care treatment. There are some complications. Case fatality of hospitalized cases, 15 to 20%. Those are the guys that are hospitalized. So look at the maternal mortality in the third trimester. That's greater than 30% maternal. That means a mom dies greater than 30% of the time with loss of. Not the fetal and neonate mortality is greater than 85%. So these numbers are probably bigger than any of the numbers that we've seen this far. Just keep those in mind. And then remember, since this thing does like to target your inner ear, deafness may be one of those complications that you'll end up even if you survive flossing. All right, Hunter. This thing occurs worldwide. Usually it's because of wild rodents. The one that we're going to specifically talk about is the hemorrhagic fever with renal failure syndrome. It's not on here, but what I want you to write on your slide deck is where we generally see this stuff. China has 40 to 50% of these cases. So one of the places you are going to find this is China. The other places that you'll find this is in Russia and Korea. Okay? So you have 3 locations, most common, of where Hunta usually is found. Okay? It's not on your slide, but you need to write it. Okay? Just like the other one, rodents, wild rodents specifically, specific, usually shed the virus in saliva, urine, and feces, and then we end up getting contaminated with that. Just how we get sick. When you say hantavirus, the other name for this is hemorrhagic fever with renal failure syndrome. Dead giveaway, right? You're going to have some renal failure issues. So this is going to attack your kidneys. Right? It's going to attack your kidneys. Here is just telling you to differentiate. We have pulmonary, which we can inhale stuff, and that'll cause us hantavirus. We're not dealing with that one right now. That's a respiratory type, but now we're dealing with the fecal oral one that's going to go down and affect your kidneys, which is that renal failure syndrome. Anywhere you see a triad, you need to remember that triad. So your triad here will be fever, hemorrhage, and renal insufficiency. If you see those 3 in a scenario, okay, and it's put in the place where it is the most common, okay, the likelihood of it being Hunta is very, very high. Okay? So keep that in mind. Whenever you see triads, make sure you remember those. We like to use those in a lot of different questions. The rodent, those wild rodents are usually the reservoirs, or the ones that pass it on to us. And then here it tells you if you're under 15, usually the disease is mild, and usually you get better on your own, so you don't really have to be too concerned with this. And we can spread it to each other, human to human, if we get infected. Incubation period is usually about 2 weeks. Each one of these phases usually lasts about 3 to 7 days. So this first febrile phase, if you look at it, there's really not much in there. Okay? Headaches, chills, abdominal pain, flushing, petechia, nothing that we really have seen. If you take a look at the very last one, you'll start with some bradycardia. So your heart's going to start slowing down, right? There's 5 phases. There's the febrile phase and the hypotensive stage that you see here, or phase. There's oliguric phase, where you stop peeing. There's a diuretic phase right after that, where you pee like crazy, and then there's the convalescent phase where you start getting that. Okay. Those are your 5 phases. So there's not really much in the febrile phase. Sometimes after the febrile phase, you may get better and not move on. Here it tells you about 11% of those patients move on. So they move on to that hypotensive stage. That hypotensive stage is one of those critical stages or phases where the illness can require intensive medical care. So if someone goes into that stage, you need to get them into the hospital because they need to be into an ICU. They need to be in an ICU. All right. And if you look at those symptoms, tachycardia, acute abdominal, paralytic ileus, convulsions, right? You're not going to handle that as a primary care provider. They need to be in the hospital. Once you go on to your polyuric stage, you can see polyuria, that means that you're just not peeing. Right? They're probably going to have to catheterize this guy because he's not peeing. Okay? And there might not be much to come out because your kidneys are being attacked at the present moment in time. Because your kidneys are getting jacked up, you're going to become hypertensive. Right? If you remember some of your pharmacology medications, some of them work on the kidney to decrease your blood pressure. But if your kidneys are not working, your blood pressure is going to start going up. In this case, at this point, you already have hypertension. Right? You have some bleeding tendency there caused by uremia, edema, thrombocytopenia. Right? You're trying to stop that bleeding so your stomach's going to go down. But at that point, at the end of that stage, 3 to 7 days, you move on to your diuretic stage. Things start getting a little bit better. You start peeing like crazy, right? All that waste product that your kidneys were not able to clean out of your system, your body's starting to like, oh my goodness, I gotta get rid of all this. You start peeing like crazy. On average, 1 to 3 liters, no, 1 to 2 liters is usually what you pee out per day. These guys start peeing out 3 to 5 liters. Way more than what we're used to, so you have to be careful with dehydration and electrolyte balance and metabolic acidosis. Because if they're also peeing out that bicarb, then there's nothing to balance that metabolic acidosis with. And then after that, they'll go into the convalescent stage, in which case it's going to take them a long time to recover because they've been pretty beat up. That kidney's been pretty beat up, so it takes them a little longer to get better, even though they feel better. This specific virus pretty much targets the glomeruli and the tuberculin cells in the kidneys, which is why it affects your kidneys. So those are the ones that it likes. It also likes the heart and the liver. All of them like the liver and the spleen. Here is some petechiae and soft palate. Here's some conjunctival hemorrhage. Okay, if you do your analysis, we really haven't talked much about your analysis. But if you do your analysis, you'll see some hematuria. Actually, you'll see some blood, right? Which makes sense because you're leaking inside. You'll see some proteinuria. So you're spilling a bunch of stuff in your urine. And then the rest of the stuff is basically the same. Right? You do your CBC, you'll have the leukocytosis, you attach your white blood cells. It's going to be a hematocrit, it's going to be possibly elevated to normal depending upon how much you bled, right, or leaked out of your vessels. Thrombocytopenia, trying to stop the bleeding. You'll have abnormal LFTs, metabolic panic, because you've lost a bunch of electrolytes and your liver's getting jacked up. And then you can do the ELISA for diagnostic. If you have PCR, you can do PCR as well. The deal with the PCR is that everyone doesn't have it, especially in some of these underdeveloped countries don't have the PCR capability. But they usually do have serology, which is why we usually like to put serology such as ELISA in there. Okay, here's your treatment. This one also has ribavirin in it. In this case, this ribavirin is going to be IV. They need to be in the hospital. Supportive care, balance of electrolytes, fluids, good things, rare complications. Okay, this recovery is going to take a little while, okay, maybe 6 months or so for recovery. Okay, here's some differentials. Okay, Crimean Congo hemorrhagic fever. This is the only one that we're talking about here that is spread by a tick. If you see something with a tick, it's probably what it is, right? It's the only one. When we get to the next block, you have a whole bunch more ticks. Don't get confused. This block doesn't really have a whole bunch. Keep in mind, this one is spread by a tick. It's off on specific areas, right? Central Asia, Congo, Africa, Middle East, Eastern Europe. Right? So it's got a pretty broad range. And there it tells you it's carried by several ticks, not one specific tick. And then we can spread it via bodily fluids to each other. This thing likes the liver specifically because it likes to jack up your clotting factors. Okay. The last one liked the kidneys. This one more so likes the bone marrow and the liver. Here's a distribution worldwide, pretty broad. Okay. Here's a whole bunch of sporadic cases that have occurred: Kosovo, Albania, Iran, Pakistan, South Africa, Uganda. Okay, so there's a whole bunch of places. This is not going to be on the test. So initially this thing looks like the flu, what it shows up as. And they end up coming back a couple of days later telling you that they're worse. Alright. Massive ecchymosis. Right? Massive ecchymosis. Not only are your capillary vessels seeping, weeping, and leaking, but it's also attacking your hepatocytes. It's attacking the cells inside your liver. And remember, some of the things that the liver does is it makes us coagulation factor. So not only are you leaking stuff out, but now your body doesn't have enough coagulation factors to clot the stuff up. So you're going to start having bruising all over. In this case, one of the things that you can highlight is massive ecchymosis, massive bruising on different parts of your body. You're going to have epistaxis. Some of the other ones had epistaxis, but in this case, you're going to have severe nosebleeds. I'm going to tell you, you're going to have hepatomegaly. Why? Because your liver's being jacked. It's affecting all your hepatocytes. Most of the stuff will usually be mucosal and GI bleeding. And then you'll have erythema in your mouth and the eyes and the neck and the face. And you'll also see, I don't think it's on here, but you'll have petechiae in the palate as well. It's usually one of the more common things that you'll see with this. Alright, so if you look at this lady's arms, that's what massive ecchymosis looks like. Massive bruising. You can see it's almost her entire arm on one side and then a portion of the arm on the other side. You can see some of the bruising starting to go up on her neck area there. Here's a little kid. She's starting to get some ecchymosis going on and bruising going on both her arms. So that's very distinctive. So if you look at this gentleman, when we say these guys may bleed, right? Because we're losing coagulation factors, stuff is seeping out from the capillaries. Right? They're going to bleed more. See that big giant bump there? When you go do a blood stick, this is what you may end up getting if you don't put enough pressure on there to stop the bleeding, because it'll continue to bleed. So for these guys, you need to make sure you keep an eye on them to make sure it doesn't continue to go on. Because if it does, you're going to have to do something a little different to make sure that it's... Yes, sir.
Is there any pattern based off where the tick bites? Like would they have more ecchymosis somewhere else?
No, because once you get a tick bite, it becomes systemic. And once it becomes systemic, it likes the places it likes, the liver in this case. And wherever things happen, some cases you don't even have to hit yourself or touch anything else. It'll just automatically start bruising wherever you see most of the vascular leakage. So yeah, there is no specific pattern. Okay, labs, same stuff, CBC, ELISA, right? Usually they show up and they already have symptoms, so usually at that point, your ELISA serology will probably be positive. But if you do have PCR, by all means, do RT-PCR. And look, the last three that we just talked about for treatment have ribavirin in it. We don't have any safe, effective vaccine for this. We don't have any specific drug regimens for any of these. We just go ribavirin at it. Okay. A lot of the studies have shown that this does help, but we don't have any of those. So just keep in mind, the last three that we just talked about have ribavirin for treatment. Okay, big things, you gotta make sure that fluid balance, correct the electrolytes. These guys for that supportive care. Here's a whole bunch more cases for aminocondyl hemorrhagic fever. This is not on the test, but just to let you know, this stuff is still happening around the world. Okay. There's some complications. Rare encephalitis. Okay. We do talk that this does become systemic, and mortality rates anywhere between 13 and 15%. It's a pretty huge range. Okay. And it's dependent on the region. Sometimes it's worse, depending on the underdeveloped country that is in. All right. Questions? Yes, no, yes? All right. For this next part, next part, sit back, relax, enjoy the soothing sounds of my voice. This is not on your slide. One of the things that I prefer is to talk to you a little bit about pathology, because some of us understand why we get certain symptoms and signs, and it's due to some of the pathology. I do this one specific, one, because I like TB. Two, because this is one of the world's worst diseases. This is one of the world's worst diseases. And some of the medications, some of these strains are resistant. So we have to mess around with specific medications in order to be able to get rid of these things, if we can at all. Right? So just kick back, you can listen, you can take notes. I think I put this slide deck in Canvas for you guys. I think one of the students asked me to put that on there. I think I did. Oh. But if I didn't, you guys want it, just let me know. Okay. So here's me being simplistic, because I am a keep it simple kind of person, right? What causes this? Mycobacteria, tuberculosis, is the bacteria that causes TB. Okay. Simple stuff. Okay. It is inhaled. It is a respiratory problem. Oh, I keep putting a point on this. I can't see. Damn it. So if you follow the little arrow at the top, that's you inhaling. Okay. If you look at the anatomy, if you look at the anatomy, you got the little trachea that goes down to your lungs. if you see the little green things along that trachea that's going down into your lungs from the bronchial stem there, that's your lymph nodes. Okay, you have a whole bunch of lymph nodes all over the place. So those little green things are lymph nodes. All right. So as you inhale the Mycobacterium tuberculosis, comes in, most common place it likes to go is the bottom or middle right lobe. Well, that's why I put that little guy there. Put him in the right lobe, right? Because here and here, the most common places it likes to go. Right side bigger, usually goes here, and eventually it'll spread everywhere else. All right? But the other thing that it likes as a most common is it likes to go close to the pleural area of the lung. Why? Don't know. That's where it likes to settle in. Close to the pleural area of the lung, whether it be the middle lobe or the bottom lobe of the right side. Most common. Okay. Now, what generally happens? Okay. If you look at, right, if you look at the right side, okay, if you look at this side, okay, my little rudimentary drawing there, right, a little macrophage, right, I don't have a point, I'm active. That guy right there is a little macrophage, right? Okay, so what do macrophages do? Macrophages go in there into the lung and they try to eat, kill whatever's bad, right? So your mycobacterium got in there, oh my God, something's going on. The body sends macrophages to go phagocytize. Okay, I want to use those big words, your choice. I like to use, they like to eat them, right? So they'll try to kill them, but the problem is, mycobacterium has a little enzyme that it releases once the phagocytosis tries to start that inhibits the phagocytosis. Okay? So the macrophage tries to engulf it, kill it, but it can't. Okay? The mycobacterium has a little enzyme it releases that does not allow the macrophage to kill it. So what happens? That means that the mycobacterium is inside that macrophage. And he usually likes to try to continue to propagate inside that macrophage. But that macrophage is not by himself, right? That macrophage releases interleukin 1, interleukin 6, and tumor necrosis alpha. Those are signals to call other macrophages and killer T cells to come help, right? So they get the signal, now they're all coming to help, right? So when they come to help, since they can't kill it, right? Since they can't kill it, they start forming this thingy right here. This is the beginning of a granuloma. Right? We talked about granulomas earlier. I'm like, what the hell's a granuloma? I don't know. Right? So this is the beginning of the granuloma right here. Okay? And all that is the macrophage. It's got the little mycobacterium in it. But now it's got a whole bunch of other macrophages and killer T cells surrounding it. That's all that is. Okay, granuloma is nothing but macrophages and killer T cells surrounding the infection. Okay? Then it moves on to the last part where it becomes caseated. Okay? Look at all the way to the right, okay? With all the funky colors on it. Okay? That's just surrounding that infection. That's your granuloma. Now, the granuloma forms because it's trying to contain the infection. If it contains the infection, that's wonderful. Okay? That means your body's handling it, it's dealing with it. Right? No issues, no problems. You can go into the latent phase of tuberculosis. In the latent phase of tuberculosis, you have no symptoms, you don't spread it. Tuberculosis is extremely contagious. It likes to hang out in the air once you cough, sing, or spit, or yell. Right? So at this point, no issues, no problems. It's going to sit there. If you were to take a chest x-ray right now, you're going to see a little dot in the bottom right corner of that chest x-ray. That's the granuloma that you look at, and the question is going to be, what is that? I don't know what that is. You know what? Let's just send them to pulmonology. That sounds great. okay, let's keep it. Sometimes we don't, but we need to do a good HPI and kind of sort of tell us, is he in the risk category for this stuff or not? Part of the HPI. Now, what happens when it escapes? What happens when your body can no longer contain it? Right? What happens if you get sick really bad? Okay? At that point, that little guy breaks out. Right? He breaks out. Where does he like to go? Usually he'll go over here. He'll go into your lymph nodes. All right? He'll go into the lymph nodes. The little green things are your lymph nodes, goes in there. Okay? Depends on how bad you are. Okay? If you're becoming like really, really bad and your immune system's not doing stuff, it may not go there, but then it may also go to the top portion of your lungs where you actively have TB. Right now, it kind of escapes and goes to your lymph nodes. That is the beginning. Okay? Your body is still trying to do the same thing. It's going to send killer T cells, it's going to send macrophages, it's going to surround it, and it's going to try to contain it. The reason why I tell you it's going to go there, because that's number one of the places it likes to go when it escapes. Number two, it'll continue to propagate in there, because what hangs out in the lymph nodes? Macrophages and your killer T cells, right? That's a smorgasbord for that little guy. Right? So at that point, you're going to end up having a widened mediastinum. So at that point, when you do another chest X-ray, not only will you have a dot at the bottom, but you're also going to have a widened mediastinum on the chest X-ray. Now, these things are aerobes. They love oxygen. Okay? The top of your lungs have the most oxygen out of the entire section. When you become active, i.e. active TB, okay, at that point you can spread it to folks, start having symptoms. It will go to the top of your lungs. It will go to the top of your lungs. And when you do a chest X-ray, you'll have a whole bunch of little black circles at the top of your lungs. That's one of the ways that you can actually tell that it's become active. All right? Now, I will tell you, keep in mind, your cytokines or your interleukins, 1,6 and 2-intercortical alpha for bit. All right, so we're going to talk about the population at risk for TB. Because when we do our HPI, we're going to know whether these folks are TB or not TB high risk people. Right? In this case, you're talking prisoners, healthcare workers, homeless people, immigrants, right? Because overseas, there's a lot of countries that are endemic with TB. When they come over here, they end up getting symptoms and then they end up coming to see you. Okay? And then IV drug users. Now, with this last slide deck here, we talk about the two things that can actually happen when you get infected. Okay? If you look at your left side, you can become latent, which means, hey, your body formed a granuloma, you have no signs, you have no symptoms, and you are not contagious. At this point, we will treat you for 3 to 6 months, generally INH. Okay? You need to treat latent. You need to treat latent because we don't want them to get it. Right? That will be your upper right corner there. That'll be your latent. Your body's taking care of it. If you go to the left side, that is what we call primary progressive or primary. So those folks are the folks that have immunocompromised immune systems, weakened immune systems, folks on chemo, folks on long-term steroids. When the microbacterium invades the body, they don't have the immune system to wall them off and start forming little granulomas. So what happens, it automatically starts invading all parts of the lung, specifically the upper lobes, and when you do those chest x-rays, you'll see those little spots on the lobes. Because those guys can't fight. So those guys are just going to automatically get it. Those are the ones all the way on the left side there. they just automatically get it, and then we just gotta fight and treat. The ones on the bottom right are the ones that we call reactivation tuberculosis. Okay? So your body walled it off, you're good, and all of a sudden your immune system dropped, you lost your macrophages, you lost your killer T cells, and now it reemerged and started going towards your lymph nodes, and breaks out and starts going into your upper lobes, okay? Causing you secondary tuberculosis. Okay? But that secondary tuberculosis is also active tuberculosis, which means at that point you can spread it and you're going to have symptoms. All right? Now, with that said, you have your interleukin 1, your interleukin 6, and tumor necrosis alpha, which does other things aside just call other cells to come help fight. Okay? It affects your hypothalamus. And your hypothalamus deals with your temperature and your eating habits, okay? Whether you're hungry or not hungry. Okay? So those will affect your fever, right? Because it deals with temperature. It affects your night sweats, it's your temperature, and it causes weight loss. It affects your eating habits. So those three are the three that you get as signs and symptoms of tuberculosis as well, along with the coughing and the hemoptysis. Okay? Now, when those things sit up top and you actually have active tuberculosis, there's other things happening, right? You have an inflammatory reaction going on up here in your entire lungs. Right? So other things that you have along your trachea are what we call coughing reflexes. Because everything is swollen, irritated, kind of compressing down, it's pushing on those coughing reflexes. So if you have tuberculosis, you're going to be like, you're going to constantly be coughing, right? Coughing is one of those signs and signals that you get from tuberculosis. As it continues to go on, when you have those at the top of the lungs, and the ones on the top of the lungs, those are the bad ones, because that already tells you that it's active TB. They cause cavitation. Cavitation means that it's eating away at your lung tissue. As it eats away at your lung tissue, it starts seeping blood into your lungs. And as you seep blood into your lungs, you start spitting out blood, right? Hemoptysis. And that's why you start coughing up blood with TB. That's when you have more, as it's gone on with the disease process. But this is why you have some of these symptoms with TB. All right. So if you guys don't have any questions on that, we will start with a slide. Hopefully that wasn't too bad. So here's a slide there. We're going to talk about TB. All right. I like these. Like tuberculosis, don't kiss me. The kiss of infection, the germ of infection. Right. This guy, a healthy look can hide tuberculosis. All right, go get a chest X-ray. Okay, a long time ago, that used to be a standard of care. Now it is not necessarily the standard of care. Okay. Tuberculosis, third leading cause of death from infections worldwide. Okay, about 1/3 of the population is infected. Okay. Here it tells you no infections every second. 5,000 people die of TB every day. Right? So TB can be inhaled if it becomes extrapulmonary. Extrapulmonary means it leaves your lungs, or miliary. Right? Those two are very similar. Extrapulmonary generally means that it's gone to a specific organ. Miliary usually means that it becomes systemic. It's gone to a whole bunch of different organs. But if it does get out of your lungs, it can cause you other organ problems. Now, the big one that I want you to really look at is right there where it says awareness of MDR and XDR TB worldwide exposures. MDR means multi-drug resistant, and XDR means extensively drug resistant. I think right now, as of the latest count, I think there's about 55 countries that have this TB problem. The TB in those countries are resistant to the standard medications that we would use. Okay? RIPE therapy is what we use, R-I-P-E. I won't get to that, I won't get to that. But those may not necessarily work on the MDR and the XDR type of tuberculosis. That really needs specific cultural sensitivity of species. So we just got to be careful on where you are when you get that TB, because that's really going to determine a lot of treatment lines. Usually if it's in the US, usually RIPE therapy. Other countries usually RIPE therapy, but there are certain countries that RIPE therapy is not going to necessarily work for us. All right, here's a whole bunch of the countries. The ones with the asterisks are the top 10 countries with TB issues. Okay, Bangladesh, DRC, remember, Democratic Republic of Congo, China, Ethiopia, India, Indonesia, Nigeria, Pakistan, Philippines, South Africa. Okay, these folks, foreign individuals that come here from these 5 countries are generally the ones that we have to kind of be careful with, okay, with tuberculosis symptoms. Here's a whole bunch of cases. Okay. There's a lot here. If you look at Texas, for every 100,000 people, 4 people have TB. Okay. Alaska, Hawaii, so Native Americans and Alaskans are high populace for TB. Okay. So keep that in mind. If they come to see you, they are a high populace for TB. Okay. So here's some casualties, some case fatalities. Untreated patients, usually about 50% of them die. Excuse me. It's not TB. All right. When we think about TB, we got to think about everything else that goes along with it. All right. So this first part there where it says social, economic, and medical are extremely important. Those 3 are really what gauges whether or not you end up getting resistance or don't get resistance. They show up to get medical care or don't show up to get medical care. Continue to spread something that they have because they can't afford to get medical care. So those things we have to look at to ensure that we can try to make sure that those people get the care that they need. The Department of Health in most states usually will provide this for free. The TB care they will provide for free, because it is such a detriment to the populace. So sometimes it's just getting your patient linked up with the appropriate people to make sure that they get taken care of appropriately. All right? And here it tells you 10 times higher in Asians and Pacific Islanders, 8 times higher in non-Hispanic blacks, and 5 times higher in Hispanics, Native Americans, and Native Alaskans. So there, it's telling you the populace that's a lot more prone to this stuff. So if you see these folks, one of the things you need to do is a good HPI, determine whether those symptoms do marry up with tuberculosis. Okay? So let's go ahead and take a break here.
On my watch, like 15
Close contacts. Anybody who has close contacts, they need to be treated, and they would be treated as if they had latent TB. We don't want to spread it. Folks that are foreign-born, they usually come over, have a higher prevalence because they've been exposed to the endemic area. Medically underserved folks with lower socioeconomic needs usually are higher risk because they usually can't afford to come see you. As you saw, we already talked about some of the racial and ethnic groups that are higher risk. Okay? Obviously, the elderly will probably present a little bit different than everyone else will because their immune system is down, so some of those symptoms may not be as prominent as others. Resident or long-term care facilities, because they're all grouped together. People who inject drugs. And occupational exposure to TB, that would be us, that would be folks that work in prisons. Because remember, TB is really highly infectious. So we talked about some of this pathology already. Okay. And tuberculosis is the main cause. We're just reservoirs for this thing, and we're the main ones that end up spreading it to each other. Usually when we cough, yell, sing, forcefully expirate. Right? Stuff goes shot up into the air. These droplets are really small. They're like 5 microns, so they'll float in the air for a couple of hours. After they've settled, usually they don't get shot back up into the air. After they settle, they usually link up with something that they come into contact with on whatever surface they're on, and that usually keeps them from going back up in the air. At that point, we can come by them and just wipe them up. It's usually what happens. In the ORs, usually we're in negative pressure rooms for infectious disease patients. Blows everything down, blows everything out of the filtered system. Usually we'll wait 1 to 2 hours, or more depending upon what it is, right? Micron size dependent, how long it's going to float in the air. This stuff usually floats in the air about 1 to 2 hours, which allows someone to come by after you, we'll say an hour later, and possibly inhale that particle. Okay? So after that, we let everything settle, and after everything settles, then we just clean everything. That's usually what we do. Okay. This one is a little bit different. So acid fast. This is part of one of those acid fast bacterium. Probably highlight that because you can stain it with whatever stain the lab uses, and it'll color it. The coloration is dependent on the stain that they use, and what that means is once I stain it, if I use an acid to try to remove the stain from it, it won't go away. So it will remain stained indefinitely. So that is one of the ways that we can tell. And it is a very specific portion of bacterium that are acid fast. And that's all that means, acid fast. Okay. Okay. 2 main types that we really talk about are the active disease and latent disease. Right, if you remember chart on the right side with that little lung, that was latent disease. Your body took care of it. Body has it. It's trying to make it go away. No signs, no symptoms, not contagious. But you're still going to be treated. Active, you have signs, you have symptoms, and you're contagious. Okay? And you're going to get treated with a lot more meds than latent. And we'll talk about the meds here in a bit. Remember, 90 or greater than 90% of the cases are latent. Greater than 90% of the cases are latent. Here it's just telling you HIV 100 times more with tuberculosis. Okay, so if you do see HIV, TB, maybe one of those big opportunistic infections that are going to affect your person. Same thing with diabetes. 3 times more likely with tuberculosis. Substance abuse, recent infection with TB within the past 2 years. When we get to the sizing of the PPD test, one of the big ones that you guys always forget is that one right there, right? So if you show up to me today and I do a PPD, that's just a little test to check whether you have tuberculosis or not, okay? And you have 0 millimeters size-wise. We'll talk about that later. But less than 2 years later, you come back to me and you have greater than 10 millimeters in size difference. According to the guidelines, you are considered to have possibly TB, and you will be treated as a latent TB person if you don't have signs or symptoms. That's one of those big ones you guys always forget. Okay. Chest X-ray findings suggested of a previous TB with no treatment. Key word here is no treatment. Okay, body weight issues. If you are underweight, malnourished, that tends to affect your immune system, so that makes you more prone to tuberculosis. There's your immunosuppressive folks, same deal with them. If your immune system is down, it makes it easier for this opportunistic infection to come get you. Right? Silicosis is something that generally happens in the southwest US, okay? Folks usually inhale silica from the air. Usually the sand blows up dust and you inhale a lot of that stuff. It starts scarring up your lungs. That also makes you a little bit more prone. And that gastrectomy, same deal, right? When you end up with a gastrectomy, you end up having to take a whole bunch of vitamins and extra folic acid because your nutrition is dropped considerably because they've taken out a portion of your intestinal tract. Right? So with that being said, your immune system tends to drop if you don't have enough nutrition to keep it up. So that makes you prone for TB as well. Okay? Here's your risk of developing TB, specifically with a concomitant infection. Right? So you may have more than one thing. Now you may have two things, i.e. HIV and TB as an opportunistic infection. And then the bigger one there, even though it says common person with coexisting HIV, is the extrapulmonary. If that thing gets into your bloodstream, it's got its own choice, right? It can either be extrapulmonary or it can be miliary. A lot of times, most common is extrapulmonary, which means it'll go to one specific organ and affect the organ. Okay? Miliary TB is very rare. And miliary is just every single organ, okay? Systemic-wise. All right, so here's a whole bunch of signs. Okay, you'll have productive cough we talked about earlier, those coughing reflexes, because the inflammatory process inside the lungs are squeezing down, causing them to make you cough more frequently. Fever, weight loss, hemoptysis, chest pain, anorexia, fatigue. Okay, those are all the signs and symptoms that we talked about earlier as to why they get them. Right? Now, if we're just talking fever, weight loss, and night sweats, okay, that can also put you into, hey, maybe this person also has cancer, and that is a different rabbit hole that you would go down. Okay, because those represent some of those B symptoms that we look for. Okay, when we talk about it becoming extrapulmonary, okay, this is what we're talking about with this slide. It can affect your brain, your central nervous system. That is what we call TB meningitis. And if you look at those are all neurologic symptoms. Okay, headaches, mental status changes, coma, fever. Okay, nothing that we haven't already seen if it affects your meninges or your central nervous system. So central nervous system, signs and symptoms is what you'll get. Skeletal TB. I would probably highlight Pott's disease. If they name something, I would probably recommend for you guys to remember what those names are. Okay? Because those are the names that they usually like to use on national exams. Okay? In this case, when it affects your skeletal system, specifically your spine, okay, it is called Pott's disease. And that's just TB going into your bone of your spine. That's all that is. And that usually happens when it becomes extrapulmonary. And there it tells you get back pain, back stiffness, extremity paralysis. Okay, it can affect joints. Okay. This is what we call a cerebral tuberculoma. The positive arrow there shows you what it looks like. Okay, for general urinary TB, right, it's going to affect your kidneys. You'll have flank pain, obviously because your kidneys are affected. Dysuria, frequency of epididymitis, scrotal mass, PID for females. Right? So a lot of those are all just GU symptoms. It can affect your skin. You'll have ulcers or wart-like lesions. And it can also affect your GI tract. Any portion of your GI tract from your mouth to your anus. Not your anus, but your anus. Sorry. So it can affect any of those, so it'll be non-healing ulcers, esophageal, peptic ulcer, malabsorption, diarrhea, hematochezia, all those GI issues. This is what we can't see. If you look in the upper right corner there, in the upper right corner there, those white spots, not good. Not good. All right. Now, when it does become widespread and you end up with septicemia, and it affects a bunch of organs, not just one, is usually what we call miliary TB. Usually this doesn't happen for folks that are usually immunocompetent, healthy folks. Usually it happens for the immunocompromised folks that have a real decreased immune system. Because this thing just overtakes the entire body. It's rare, okay? It's not as common as the extrapulmonary stuff, but those folks are more at risk for getting miliary TB. And as you can see there, weakness, weight loss, headache, cough, generalized lymphadenopathy, hepatosplenomegaly. It's going to affect a whole bunch of different organs there. Multi-organ dysfunction, okay? Adrenal insufficiency. And if it's untreated, look at that mortality rate, 100%, close to 100%. But we'd already be aware of those guys because they're immunocompromised. So we'd already be aware that they need more care or more aggressive care. So here, pulmonary TB, usually you'll have abnormal breath sounds, especially over the upper lobes when it's active, right? Because remember, these are aerobes. And because they're aerobes, when they become active, they let go into the top of the lungs. And when you listen, they'll have abnormal breath sound. Now, there's a whole bunch of other places extrapulmonary TB can occur. If it affects your cervical lymph nodes, it really likes to do that. If it affects your cervical lymph nodes, it's got a name. It's called scrofula. Scrofula means TB of your cervical lymph nodes. Okay? One of those crazy words that they add into it. Right? If it affects your pericardium of your heart, okay, that can lead to constructive pericarditis. Okay? Remember, if this thing makes it to your heart, this thing can try to start fibrosing or calcifying the outside part of your heart. And when it starts to do that, it constricts your heart, which is why it causes pericarditis, constricted pericarditis, all right, of your heart. If it affects your liver, it's going to cause inflammation. What's inflammation of the liver? What is it?
Hepatitis.
Hepatitis. Okay. Inflammation of the liver is hepatitis, right? That's what you're going to get from TB, because it's just going to cause generalized inflammation of your liver as it attacks your hepatic cells. It's going to attack your adrenal glands, or it can attack your adrenal glands. If it attacks your adrenal glands, it decreases the production of cortisol, leading you to Addison's disease. When you get, you guys already done endocrinology? Okay? No? Yes? No? No? Not yet? Okay. All right. So the decrease in cortisol that's created by your adrenal glands causes you to have Addison's disease. Not good. And then if it does attack your long bones, okay, not just your spine is what we call POTS. If that's your long bones, now we're talking osteomyelitis. So extrapulmonary TB can affect a whole bunch of different parts of your body. Right? So how do we figure out whether you're dirty? The cheapest and easiest way that we have found is to do a PPD, TST, or Manto. All three, they're the same thing. We will just use different names. Okay. What else can you do? You can do a smear and culture. That technically should be your gold standard. Okay. That culture and smear should be your gold standard. Okay. That smear, what you're going to do with the smear is you're going to do that acid-fast thing. That's going to tell you, and then you're going to do, you can do what they want you to do is you can take your days, same time, early in the morning, send them off for cultures. The blood or the sputum culture will take anywhere from 4 to 6 weeks to grow out. It will take anywhere from 4 to 6 weeks to grow out. So it's a slow growing culture. Okay? You got stuff in other places, people do biopsies area. bone marrow and liver. All right. Now, for folks that are from certain countries, don't have that list, that use BCG vaccine. What BCG vaccine is a vaccine against tuberculosis. Some countries use that. The problem with that is that when you do a PPD, the little thing that they stick right under your skin on your forearm, it may come back positive. Sometimes you can ask your patient, hey, do you ever have a BCG vaccine? You know, I've been surprised. A lot of patients that I've asked that, they're like, yeah, I got that when I was a kid. It's kind of nice, right? Because now you know you need to do something different. If they do have BCG, my recommendation and the recommendation of these guys are to do a quantiferon gold test, it's an amino acid test, and that completely negates the BCG. So it'll tell you whether you are or not positive. Okay? That's what that QTF is, quantiferon gold. You can do PCR, you can do a line probe assay. We don't do that here in the US. Line probe assay is similar to a PCR. I believe India is probably the only country that really uses that. We don't really use that here. All right, so if you look at all those little red spots there, those little red lines, that's the bacterium. They stained it, and they look red in this case. If you go ahead and try to spray some acid base and get all the coloration off, it just doesn't come off. Hence the acid-fast bacilli. This is what your tuberculosis looks like on culture. Okay, nice little clump there. We do have PCR. You can use PCR. That's another good way to do it. Right? There's a bunch of screening tests you can do. You can do CBC count. You can do chemistry. You can do LFTs. You can look for alcohols. You can look for total bilirubin. You can look for uric acid. Uric acid is usually associated with stones, but it may be increased with some other stuff. Creatine, sandil, kidney function, and right, we saw that it was 100 times more likely with HIV. So one of the things that you can probably check also would be the HIV status of the individual that shows up. What does that first line say?
Just a query.
Should be the first test status post positive PPD. I guarantee one of you will get that wrong on the test. I don't care how many times I stomp my feet, smack the podium. Tell you, the first thing you do after a positive PPD is take a chest X-ray, right? Because that's going to determine whether or not you are an active or latent TB. It's a little thing at the bottom, or it's a little thing at the top of wide media stuff, right? First thing you do after a positive PPD is take a chest. Questions? No? Okay. We'll see. I'll make fun of you if you get it wrong. I'll just tell you right now. In front of your friend.
He pulls up a list. Stupid.
So, okay, main reason why we're looking for progressives, all right, we're looking for reactivation. That tells us, right, is down at the bottom, where you probably just have a granuloma, or as it already spreads to your lymph nodes, has it already gone to the upper apices of the lymph. Okay, that's really the stuff that we're looking at. We're also looking for cavitation. Right? You may see a dark spot, and then when you do your lateral, you'll see that it's indented into your lung tissue, showing that it's eating away at your lung tissue, right? So you'll also need that lateral to look at. So that's one of the reasons why we do a chest X-ray. Now, specific for miliary TB, it looks like snow. It looks like little 2 or 3 millimeter blue dashes throughout your entire lung, all of your lungs. Okay? It is a very distinct, and we'll show you here that in a bit. Okay, so that looks like a possible little mass there in the middle aspect of the lobe. not necessarily sure there. Okay. You can see a mass in the upper aspect of the lung here. Okay. I'd like to positively highlight that with my little pointer because it doesn't go up on the board there. So this one also has some hyaluroniopathy going on. Okay. And you can take 1/3 of that lung shadow, heart shadow, put it on the other side, so your heart rate's fine. Good. Here's some apical consolidation. So if you look at the upper right side of the patient, right, it looks dark. And then you got 2 dark spots in there. Okay. Those dark spots, because you have the cavitation, probably already tell us consolidation, probably tell us that those 2 dark spots are cavitations. That means that it's already eating away at your lung tissue. Okay. It's got another spot in the upper left side too, right under his clavicle. All right, see this lung? Looks like little snow throughout the entire lung on both sides. Okay. Usually 2 to 3 millimeter little dot dashes throughout the entire lung cavity on both sides. That is what miliary TB looks like on chest X-ray. They call it miliary TB. They say that they look like millet seeds that are scattered throughout the lung fields, all lung fields. And then this one you can really see in a hyaluroniopathy really well. So if a patient has active TBA, you need to put them in the negative pressure isolation room, right? It is contagious, so you don't want them coughing and talking and spreading that stuff everywhere. You should wear an N95 mask whenever you get to wherever you're going to go. They're going to make you go to, I think it's community health. Occ Health, yes, thank you. They make you go to Occ Health. They'll measure you for an N95 mask, and then they'll give you the right size that you need. In case you get exposed, you'll have the mask that you'll need. And they'll tell you the appropriate size that you're supposed to wear. Then follow universal precautions. Hey, wherever you go, you need to read the SOP to tell you how to handle, in this case, tuberculosis, wherever you're going to be. Okay, everybody has a slightly different way of handling things, specifically for infectious disease issues. So my recommendation for you is whenever you get to wherever you're going, look at what their SOPs say for infectious disease type stuff. Okay. And then talk to community health because they need to go do contact tracing to figure out who else has been around you if you have active TB, so that they can make sure that they get treated as well. This is what your N95 looks like. It's hard to breathe. All right, so this is treatment. We're going to go with the 6-month treatment. Okay, that is one of the more common treatments. There are a whole bunch of treatments. There's 9-month, 4-month, 3-month. There's a whole bunch of different kinds. It messes with the medications that you use. It messes with the dosing that you use. It messes with how often you take them during the time period. Right now, we're going to the most common. The most common would be the 6-month time period. If you remember RIPE, R-I-P-E, that is the medication that you will be using. Okay? R stands for rifampin. I stands for INH or izanacid. Okay, P stands for pyrazidamine, and E stands for FM-Butyl. 4 medications that you're going to be taking. All right. Now, so it gets a little confusing. Okay. The first 2 months you're going to take all 4. The first 2 months you're going to take all 4. The last 4 months, you're just going to take 2. The last 4 months, you're going to take INH and rifampin. Okay. So you have 4 meds. First 2 months, you take 4 meds. The last 2 months, you take 2 meds. Okay. And the 2 that you're going to take away would be the FM-Butamol and the pyrazidamine. Now, in that interim, you should have done a culture sensitivity. That culture would have come back and told you whether it was resistant or not resistant to the standard medication protocols. If it is not, then you can leave the ethambutol on. If it is susceptible, then you can take it off. Okay? That's the only caveat here. If the medication is susceptible to the standard medications that you're going to leave them on, you can take ethambutol off. If it is resistant, you leave ethambutol on. Okay, and then finish with a total of 6 months. Alright? Now, once you start the regimen, usually about 2 weeks after is when generally they consider you non-infectious. You don't spread it anymore. Usually it takes about 2 weeks after you start the medication for them to think that you are no longer contagious. So either you can still isolate them or you can have them wear their own mask. But usually it takes about 2 weeks. Now, the other caveat is that at that 2-month time period when you're about to take them off the medications, you can go ahead and do another culture to verify whether the stuff is actually somewhat working right. That is a caveat that you can add at that 2-month time period when you start switching them off the other 2 medications. Here are some complications of TB. This picture right here shows an aspergilloma, but if you see that big hole that's there, that's what a cavitation looks like. TB usually causes cavitations, that's generally what it looks like. Right? And because it's burying itself and destroying that tissue is how it ends up getting some of that blood to leak into your lungs for you to cough it out. Here's a bunch of differentials. Look at that, fever of unknown origin being one of them. Okay. Now, just because you see a little block spot in the lung does not mean that it's TB. We've covered histo, we've covered blasto. Remember that those are inhaled. And if you remember, we said, hey, they also cause granulomas in the lung. So just because you have a spot in your lung does not mean that it's TB. You've got a whole bunch of other possibilities. First, you need to figure that out by doing review of systems questions and HPI. Okay? Right place, transmission, mode, and then looking at what some of those signs and symptoms are to denote some of the differences. All right? And here they tell you it could be other things like lung abscesses and liver, lung cancer. So we do have plenty of other things that it could possibly be. How many of you guys put in PPDs before? Okay, so we got quite a few people. All right, good. So we're just going to talk about that real quick. Right? On the needle, you have a little bevel. One side's a long pointy side. If you flip that bevel over, it's a little hole on the other side. When you put in the PPD, it's really subacute. The hole will go up, you can bury it under the skin and then just fill it up. Okay, you'll get a little raised fill up right under the skin. Okay. It's 0.1 ml on a 5 cc tuberculosis syringe. That's what you do, put it in. All right. The key is to make sure that you have the little bubble, number 1. Number 2, they have to come back in 48 to 72 hours. They have to come back in 48 to 72 hours. That is when you actually check for a reaction. Okay. A big part of this, and we'll show you when we start getting to some of the pictures, the erythema, okay, the big red spot that may or may not show up, is not what you're measuring. What you're measuring is the induration that is formed. after the reaction occurs within those 48 to 72 hours. Okay? So a lot of times what I tell folks to do, right, because they'll look at a big giant red spot right on the forearm, it's like, wow, it's huge. I don't care that it's a giant red, not what you're measuring. What I usually tell folks to do is just take a pen and then just drag it down the red spot till you get to where you put in the PPD, until you feel like a little lump, okay? And what you're measuring is lump to lump from one side to the other, okay? If there's no lump there, that's great, then it's probably 0, even if they have a big giant red blotch there. Right? You're measuring the induration of what's occurred after 48, 72 hours. That is how you measure this thing. Okay? You gotta be careful, right? You may end up with some false negatives here, especially if you do the measles, mumps, rubella, or any other live vaccine. It may stimulate this and cause you a false negative. 2 things to remember: if this thing is positive, make sure you do a chest X-ray. If it is positive, you can also ask them, hey, have you had the BCG vaccine before? If they are not sure, and they are from an endemic country or from overseas, just go ahead and order a quantiferon gold. Just go ahead and order. Really, the quantiferon golds fall under what we call interferon gamma release assays. So you might not see quantiferon gold, you may see interferon gamma release assay. Quantiferon gold is a specific name of a specific interferon gamma release assay product. Okay. So see that red blotch? If I were to drag my finger or a pen and I hit those little marks, it would feel like there was a little lump. Okay, it feel like a little induration. Okay, and all you're doing is just going across and measuring from one point to the other in millimeters. In millimeters. Okay. For example, this one has giant erythema. You don't measure all the way from the erythema edge to the erythema edge. You can almost see the elevation of the induration of the central portion. That one you can mark, and that's really all you're going to measure. People always get confused with those. Now, you need to remember these next couple of slides because of the definitions of what numbers you need to look for the folks that are at risk. Okay? We have 5, 10, and 15 millimeters. Pretty easy, it goes by 5. Okay? Hard part for you guys is to remember what's in each. Okay? So if it is larger than 5 millimeters, that is considered positive for people that are close contacts of newly diagnosed TB patients. Anyone that's HIV positive, organ transplants, long-term steroid use, fibrotic lesions on chest X-ray. Right? So those are technically folks that are neutropenic or immunocompromised. Now notice, this one specifically has HIV positive in it. All right? If you go to this one has IV drug users known to be HIV negative. So don't get those confused. And if you look at these are more folks that have comorbid conditions. Okay? Rare diabetes, head and neck carcinomas. And this one is anything greater than 10 millimeters on induration. Now look at the one that says recent converted. So 10 millimeter increase in the past 2 years. So if you showed up in my office and I gave you one a year and a half ago, you come back a year and a half later, close to 2 years later, I give you another one, and it's like, hey man, your last one was 0. This one's 11. Guess what? I'm about to treat you for latent TB, because that makes you positive. Okay? According to the TB guidelines, it makes you positive. These are based off the guidelines. Recent immigrants from high prevalence countries put you at 10 millimeters or greater. So you need to know the folks that fall into each of these categories to determine whether you're going to use 5, 10, or 15 millimeters to measure for positivity. All right, status post that PPD. Right? Remember some of those countries, Ethiopia, Indonesia, Nigeria, Philippines, South Africa, okay? Okay. What else is at high risk? Right? Prisoners, healthcare workers, that's us. Right? We're dealing with some of these kind of patients. So we are at risk. Okay? Homeless folks, immigrants. This is, I think, the list that I used in the pathology slide. Okay. Who else do you think is at risk here? That's us. That's us. Okay? Aside from being healthcare workers, okay, that's us. In an endemic country, surrounded by people. Okay? Well, that's your military population. This is who you're going to be taking care of. Right? Okay? So everyone else who doesn't fit into those categories that are healthy, like us, when we look at the PPD, it should be greater than 50 millimeters. That would make us positive for tuberculosis. Okay? And then we start doing what's next? Oh my goodness, one person said chest X-ray. Okay? Right? So understand, if you get a positive PPD, the next thing you do is a chest X-ray. So if I'm a healthy person and I got a 10 millimeter in duration, are you going to do a chest X-ray on me? Yes or no? All right. So I'm a healthy guy. I only got 10. Okay? My magic number is 15. So if it didn't go beyond 15, then I'm good. Okay? Oh, you're right. Yes. So I'm a healthcare worker. Right. So it would be 10. So would I be positive? Yes. So look at that. Now I gotta go get what? I gotta go get a chest X-ray. Or okay. So, see, so you have to make sure that you figure out the population that you're falling in under, so that you can look at the number that you're going to make positive or negative. Yes, sir.
So, which one could put your medication for 6 months?
I'm sorry, I can't hear you.
On which one they put your medication for 6 months? The 5, the 10, or the 15?
Okay, so if you don't have any symptoms, and when they do your chest X-ray, you don't look if you have active TB, okay, that puts you into the latent category. If you're latent, we'll treat you for 3 to 6 months, depends on which one or where you're at. If you're active, we're going to follow that 6-month right period. So if any of these turn up active, right, because we have to differentiate them, we'll do the right therapy. Okay? Later on, we'll keep going, we'll show you how to treat for latent. Latent's just INH, okay? Or rifampicin, depending upon what you want to use. Okay? But if you are active, you treat active with right therapy, and as we go on, latent is usually treated with one, either INH or rifampicin. All right? So we have to be careful with high positives and high negatives, right? Those folks that have BCG, they give us a false positive. If you have some other mycobacterium, not necessarily Mycobacterium TB, that can also be positive. So we have to be careful. That's why we do HPIs, that's why we do chest X-ray, we have to do some of those other measures. Right? If you do have those, and you could do that interferon gamma release assay or quantiferon gold, either way you look at it, they're the same. Okay? We'll go ahead and do that. You get a whole bunch of false negatives, especially if you have some blood issues going on. Right? So if someone has a fever, someone is sick, don't give them the PPD. All right. I have never seen anyone do the 2-step program or the 2-step testing. If that's the case, then we can just do the interferon gamma release assay. Usually we'll do this for folks that have the BCG. If you don't have access to send them to the lab for the interferon gold. All this is is you have them come in, do the PPD, you have them come back 48, 72 hours later. You're not gonna read it. What you're gonna do is you're gonna put another one in, and then you have them come back in 48, 72 hours, and then you read it. Okay. What you're doing with the first one is you're actually stimulating the body to react, and then your second one will be the actual reaction that your body has. That's really what they're looking for here for past infection. Again, I've never seen anybody do this. We just send folks off and give an immune release assay on quantiferon syndrome. Okay, so this is the treatment for latent TB. Okay, so if you don't have active TB, right, latent is greater than 90% of the folks. So if you have latent TB, this is how we're going to treat you. We're going to treat you with INH. We're going to give you pyridoxine, which is vitamin B6. Right? The reason why we're giving you that is because INH causes peripheral neuropathy. You guys remember that from pharmacology. Right? INH causes a lot of peripheral neuropathy, especially taking it for 3 to 6 months, or in this case 9 months. Right now, if you're not dealing well with INH, you can switch it off to rifampin. Okay? Or if you have resistance to INH, right, whatever TB strain you got, you can switch over to rifampin. Okay? But it's generally one TB med, and that vitamin B6 is mostly just to prevent the peripheral neuropathy. It's not to stop the TB stuff. All right. Both of these meds, INH and rifampin, have some pretty rough side effects. Both of them get processed through the liver. You remember that from pharmacology, and both of them, at certain doses, and depending upon if you're taking other medications, may cause hepatotoxicity. So before you start these things, make sure that you do LFTs. Check that liver to make sure everything's okay. Right. There is a thing that we call direct observation therapy, DOT. If you look at the bottom there, INH and rifampin can be done weekly for 3 months under direct observation therapy. Right. We don't really do that stuff anymore because it's very labor intensive. We have to have folks come in, or you have to go someplace, you give them the pill, and you watch them take it. We used to do that a long time ago, but we stopped doing that. Since there are some public health places that are actually starting to do it again, but it depends on where you are. Okay? In the military, it's a lot easier to do. It's like, hey, I need you here every morning at 08, and then you can watch it. Right? But in civilian sector, it's not that. All right, so here's a whole bunch of different options, right, for latent TB. We're just going to go with the first option where it's INH paroxysm or rifampin for 9 months. I'm not going to worry about all these other ways. So this is just to let you know, for direct observation, we've got 3 other options here, aside the one that's on that last previous slide. I probably will not test you on these just because there's a lot of different ways that you can treat TB. So we'll stick with 2, right? Treatment for active and latent TB with INH and or rifampin. Not and, it's or. Okay, here are a whole bunch of folks that are at high risk. Then you should definitely check their LFTs before you start giving them INH or rifampin or the right therapy. Right? Especially those alcoholics. Right? Because if they are abusing their liver already, it's only going to get worse with the tuberculosis medications. Right? So there's a whole bunch of folks here. You can see that they've got pregnancy here. What do you do with pregnant folks? Can I give them INH? Yes or no? Remember pharmacology?
No.
Yeah, I don't remember pharmacology. Oh, we got both. You guys can't use them, so yay or nay? Will I give a pregnant person INH? No. Who else? I answered that was wrong. Damn. So now we know that the answer is probably yes. INH has been shown to be safe in pregnancy. Rifampin has also been shown to be safe in pregnancy. Roxadine has been also shown to be safe in pregnancy. Ethylbutamol, on the other hand, is questionable. Now with these, I would generally say, hey, you need to go talk to the IV doctor. A lot of times, they can probably put some of this stuff off until after they deliver. But remember, it's based on what that person shows up with. If it's become extrapulmonary, it may affect the baby. So now your IV guy and your OB really need to work together to figure out what they can and can't do. Sometimes we have to look at risk versus benefit. And we'll talk more about that risk versus benefit when we're talking about that maternal case, right? If you have a high risk of maternal death, right, and you're pregnant, and I can give you something that may make you better, but what I can give you is category X. For pregnancy, do I give it to you? Yes or no? Right? That's a decision that you, specialist, and the patient need to discuss. Right? If you look at most of the literature, it'll tell you, hey, your first job is to make sure that mom survives. So then would I give her the medication? Yeah, because it's telling me that I really need to make sure mom survives. Mom may not want that. Right? So those are questions. These are going to be hard risk versus benefit ratios that you guys are going to have to talk about with your patients. Okay? Here's some drug side effects of these medications: hepatocellular disease, peripheral neuropathy, interactions with fentanyl for isoniazid. Rifampin can cause you thrombocytopenia. It can accelerate drug clearance, which is not going to help if you need to have that drug stay in your system longer. Ethylbutamol will cause you visual changes. Ferumoxypine will cause you hyperuricemia or symptomatic hyperuricemia. Right? Those are not good. So, do any of them cause issues with OCP medications? Yes, right? Rifampin does. So we need to tell that person, hey, don't trust those OCP medications. You need to use a different type of birth control. So keep in mind that these things have a whole bunch of side effects that you really should talk to your patients about. All right? Questions? All right. We're done for today.